Genomics and Smoking Cessation, presented by Amy Thornberry, a Doctor of Nursing practice student at Texas A&M University in Corpus Christi. This is an evidence-based research study on genetics, smoking behavior, nicotine addiction and metabolism, and cutting-edge treatment for tobacco cessation. Smoking addiction is a complex disorder. It has environmental influences, but also it is affected by unique underlying biological interactions. By translating genomic research, the DNP may discover effective, personalized smoking cessation treatments. It should be no surprise that smoking continues to be the leading most preventable cause of chronic disease in the U.S., and it is the leading most preventable cause of mortality in the world. In 2015, over 15% of the adult population in the U.S. considered themselves smokers. Despite advancements on smoking cessation, 1 in 5 adults smoke, and half of those are addicted to nicotine, and most smokers have made up to 5 attempts to quit. This study will focus on genetic factors as biological predispositions for a disorder termed nicotine addiction. So the question is, are there genomic translations for smoking cessation? The history of tobacco smoking dates back to 5000 BC with the American Indians and was introduced to Europe in the 1500s. Ironically, during the smoking inception, Europeans believed tobacco had healing effects. A Spanish doctor claimed 36 different healing powers in his book, Nicotiana. Since the tobacco influence has spread globally, there are almost 980 million smokers in the world. There are comparative subgroups identified for smoking prevalence. Economic disparity, as low education, low income, report higher rates of smoking. Nicotine dependence is linked to mental illness, including depression and anxiety. Men smoke at higher rates than women, but women may be less likely to quit. Europeans and blacks smoke at considerably higher rates than other races. Although there were limited studies on family susceptibility, studies on heritable components that are found with twins for addiction have genetic variations linked to nicotine metabolism. This leads to the research question: could knowledge of individual genetic responses to nicotine impact the way we treat and manage our patients? Could individual genetic responses for nicotine dependence improve smoking cessation? The patient population to target are adult smokers and whether they are genetically predisposed to nicotine dependence. Intervention of smoking cessation treatments, for instance, in selecting genetically aligned pharmacotherapies for smoking cessation that have been identified through clinical testing. The C is the comparison of intervention for traditional treatments and new cutting-edge pharmacotherapies for addressing smoking cessation. The O are outcomes and measures of treatment success and failure of smoking cessation rates compared to previous rates. And the T is the type of study, as in randomized controlled trials and meta-analyses of the literature for therapies using genetic testing for nicotine dependence. A final evaluation question is whether these evidence-based studies are valid, reliable, and practical, and can be used as a scientific basis for informed decisions, and whether this leads to better patient outcomes. I reviewed a number of gene studies, and these were on the risk of nicotine addiction. One large study was by Culverhouse, and it indicated that there was an association between a common inheritable gene cluster for Americans for European descent and African ancestry. And they found that there was a single nucleotide polymorphism with this gene which was associated with nicotine dependence. Now, there was a significant probability that these two subgroups carry 1 or 2 copies of the nicotine dependence risk allele. And there were also multiple studies identifying 2 single nucleotide polymorphisms in a variant which are biologically functional and associated with tobacco-dependent phenotypes. Additionally, I found a meta-analysis on a gene variant in human chromosome number 8 that was associated with nicotine dependence. And then lastly, there was also a study in regards to genetic evidence that we found on biosynthesis of nicotine for the cytochrome P50 enzyme, and it was a variant that was linked between nicotine metabolism for smoking intensity and frequency, which is quite interesting as far as smoking cessation goes and using therapeutics for that. Now, how are these genetic studies implicated for smoking cessation in our practices? So, looking at genotypes' influence on an individual's response to pharmacotherapeutics, these affect outcomes for clinical application, which applies to our practice and how we treat our patients. You know, if you consider that the genetic variant, for instance, in a cytochrome and the metabolism for smoking cessation rates and nicotine replacement therapy, it would be different because of the response of the gene variation and the nicotinic receptors. I found another meta-analysis on allele variations and how this affects nicotine dependence, but not necessarily cessation rates. So this indicated that we would need further studies. Now let's look at smoking cessation and continued abstinence. A meta-analysis of 150 controlled trials for smoking cessation showed that there was a gene related to increased long-term smoking abstinence. This is a reliable study indicating abstinence is better achieved with a genetic variant for nicotine dependence. Interestingly, evidence that a genetic relationship for nicotine dependence and smoking cessation exists, although further investigation is needed to determine if the impact of genes might play on smoking cessation. So let's talk about genetic testing for nicotine addiction and how we would actually apply this. You know, I mentioned earlier that mental health conditions are related to higher rates of smoking, but testing for general addiction tendencies tends to not quite be established. They haven't identified a single gene causation, so that needs further investigation. And then there were some companies like Gene Planet that claimed to test for nicotine dependence, but actually this was more of an individual genomic response to medications and what that metabolism rate would be, and nicotine is included in that. So that is more of a general preemptive testing. Now, of course, that would be more practical, and you could get a whole series of tests on an individual. Another consideration was that most commercial testing labs don't meet quality criteria. So I did find some labs, Hoffman and Luminex, that specifically test for nicotine metabolism, and they did meet quality criteria considerations. And then another concern are costs of tests, and these vary from $200 to $2,000 is what I found. But then again, that does not even compare to what the cost of nicotine dependence would be. Let's talk about counseling and the clinical relevance of doing genetic counseling, testing with our patients. I found a study that was on counselors and psychiatrists. 100 of them were surveyed, and it mentioned that they would actually refer their patients to genetic testing, understanding that it might help with treatment decisions. Unfortunately, I did not find any studies for nurse practitioners, advanced practice nurses, on their attitudes toward pharmacogenetic testing and counseling. Now, looking at the actual testing, if you did preemptive testing, it might be cost effective and efficient because it includes a whole series of tests, but you know, it's not selective for cessation interventions necessarily. If you did have a single test run for nicotine dependence, then you know you're focusing on that specific variant, and it's not quite as efficient and practical as a preemptive panel would be. So you have to look at how you would be doing your testing and how this would apply to your actual patient and what their needs would be. Another consideration might be to have preemptive testing in your medical records for your patients. That way, if you have certain considerations for prescribing, be it for nicotine treatment, you've already got the information in their medical record. Let's look at the ethical, legal, social implications we have with smoking, nicotine addiction, and how this applies to the whole realm of the person. So nicotine addiction has been depicted as a bad habit, and there's a lot of negative social implications for the patient themselves and their families. This would be very important, understanding now that it's a genetic disorder and that it's actually a disease. So being addressed like that makes it much more palliative for the patient, and they can be identified more specifically for treatments that are precise in managing the intervention with their therapies. Patient education also about testing would be important from a nurse practitioner standpoint. You'd want to discuss the purpose and how the results may impact their treatment. It might be beneficial for them understanding that an abstinence effect might be felt if they understand the genetic connection between nicotine metabolism and using nicotine replacement treatment. You know, the discovery of these genes may really ultimately assist us with caring for our patients and providing better care. So ultimately we want to use these treatments and minimize any kind of behavioral and mental stress that's associated with an addictive illness and that smoking lifestyle. And then, you know, it really impacts families and their children. You think about secondhand smoke. These are really some changes that you can make that would be considerations for that patient and their family with good positive outcome. So now, what is our role as an advanced practice registered nurse? You know, number one, we want to continue our research. That's very important. We need to understand genetics and how pharmacotherapies might be associated and applied more accurately for smoking prevention and cessation, and also abstinence, as we had discussed earlier, on certain gene variations. Now, we need to remain diligent in our professional education regarding genomics, understanding testing, and how we can use these interventions to educate our patients, also in changing policy and practice. So that's, you know, those are considerations, along with assisting our patients. The one takeaway here in tobacco cessation, and it's been evidence-based, are incorporating the 5 A's. So if you take anything away today, don't forget to address each one of your patients. Always ask if they are a smoker and make those appropriate referrals and encounters from that point forward, because it is been proven that what we do and what we say to our patients makes a big change for them, and we have been able to reduce smoking rates. Also, talk to your patients and give them that educational information and all the resources, and make sure you have those available. As I'm working on my doctorate project, I found this study to be particularly interesting because I found that, you know, we might make a clinical change and there are some future implications. The genetic research that I looked at showed that there were emergence of personalized medicines and implications in our clinical practice to treat for nicotine dependence and looking at long-term abstinence. You know, we're not doing that just yet, but that's on the edge. So there's future opportunities, and we need to continue the research to improve smoking cessation outcomes because it's so good for our patients. We need to do this. It's detrimental to the populations. And if you look at minimizing any kind of mental stress due to nicotine dependence and using the specific therapies for that, we certainly want to incorporate that into practice. So our future focus is to identify these high-risk groups and see if we can target those specific preventative interventions. Lastly, don't forget about the interventions that have already been proven, and utilize your 5 A's for smoking cessation. Ask, advise, assess, assist, and now we can arrange for allele identification in the near future. So in conclusion, as we ride off into the sunset, we would like to feature the star of our presentation, the Mendelian Man, who is now a descendant of the Marlboro Man. You know, he may not be quite as handsome. He's got the face of Gregor Mendel superimposed on his face. It was a creation of mine. And if you notice, he's got, for his ropes and lassos, those are jeans that are draping off the saddle and his arm. And then don't miss the prescription that's coming out of his pocket instead of a pack of cigarettes. So I'm hoping in the future this is something that might be used as an advertisement for what we can do to help our patients. And lastly, remember what our surgeon, our former Surgeon General mentioned. Starting today, every medical provider in America should treat tobacco dependence as a top priority. So consider that in what you do with your research and where you take it in clinical practice to help our patients. If you have any questions or comments, I have left my email right there in the lower right corner. Thank you so much.